Test, 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 1, 2, 1, 2. Test, 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 1, 2, 1, 2.
Good morning. The subcommittee will come to order. I want to welcome our witnesses to discuss the efforts to modernize VA's appointment scheduling process. 10 years after the wait time scandal, it's still too difficult for veterans to get appointments in the Veterans Health Administration or in the community. Some members of this committee have been eager to get into arguments about VHA care versus community care. I believe veterans should have all the information, and the VA should respect their choices. I was charged with making sure our veterans get the care that they've earned, when they want it, where they want it. Period. I can tell you in Montana, community care is an absolute necessity. But the reality is both systems are still far too bureaucratic and difficult to navigate. It's also still too complicated for the VA employees to manage scheduling. These IT systems have not been a high priority, and the projects that are consuming, the lion's share of the IT budget do little to solve the problem. I'm glad to see our witnesses working on the integrated scheduling solution, the clinical capacity search tool, and the clinic configuration manager to improve VHA scheduling. I question why the department waited so long to start these projects and why some of them will take so many years to complete. But without a doubt, the goals are worthy. I expect our witnesses to stay the course and deliver these systems on schedule and on budget, which is another big problem that we've had with many of the IT programs. Our veterans would have been much better served if the VA had not abandoned the medical appointment scheduling system, MAS, in 2019. This project had implemented Epic scheduling system and patient portal in Columbus, Ohio, and they were working well. But the VA leaders at the time made a special effort to eliminate it, paving the way for Cerner, a name that we've had come up in this committee many, many times, not under good circumstances, to duplicate the work and install an inferior system. This was a disastrous decision that we are all still paying for. I also expect our witnesses to explain how they're going to fully implement the external provider scheduling system, which includes the software of a company called WellHive. WellHive enables direct scheduling, which means VA schedulers no longer have to play phone tag for hours to hunt down open appointments with community care providers. Instead, they can see each participating community care provider's scheduling availability in real time on one screen. They can schedule the veteran's desired appointment with one call. WellHive software has proven successful in the medical centers that have been permitted to use it. According to VA's own statistics, it has accelerated the overall community care referral and scheduling process from 26.6 to 17 days. The status quo phone tag method takes days or weeks and many phone calls before a veteran can get scheduled. I know many veterans who are watching this can certainly relate to this problem. According to the VA's website, WellHive enables staff to schedule appointments in under 6 minutes. The medical center employees have given it rave reviews during the committee's staff's oversight visits. It seems to be working. Yet, we continue to see VA make confusing decisions that hold the project back. Early on, there were caps on how many schedulers at each medical center could use WellHive. More recently, the company has complained that its efforts to sign up new healthcare providers are restricted. Now VA tells us that WellHive's system will be turned off in 4 medical centers where it was already implemented, and the planned rollout in fiscal 2025 will be dramatically scaled back. I'm well aware of the VHA budget shortfall. I think the House made the right decision yesterday to get a complete explanation of the shortfall rather than to hand over a $12 billion supplemental appropriation right away. I have no doubt that Congress will get to the bottom of the situation and prevent any veterans' care from being disrupted. That being said, it would be incredibly short-sighted to cause lasting damage to this project with budget cuts that will quickly disappear everywhere else. I have serious concerns that the current leaders of the Department of Veterans Affairs might be intentionally undermining this project and making veterans' health care slower and more difficult out of political hostility to community care. I hope that's not the case. Today, we're going to dig into these decisions and the thinking behind them. Because veterans appointment scheduling is too important and the status quo is too broken to let any of the projects we're discussing today slip into failure or neglect. With that, I will yield time to Ranking Member Shurfluss McCormick for her opening statement.
Thank you so much, Mr. Chairman, and thank you so much to our witnesses for being here today. This subcommittee has spent a lot of time discussing VA's transition to its new Oracle electronic health record. Lost in the conversation has been the Veterans Health Administration's critical need for a new appointment scheduling solution. Appointment scheduling is the foundation of veteran access to care. The current process and the system that support it, and weeks or months to the time that the veterans wait for their critical medical appointments. This should not be the case. Instead, we should be creating solutions that provide better visibility to care, whether it's sought at VA or in the community. Veterans deserve as much. For more than 20 years, VA has attempted to modernize or replace its scheduling IT system. It has been decades of modernization efforts with little to no success. In fact, most of the efforts have been abandoned. In just the last 10 years, we've seen 4 partial efforts to create this functionality for veterans, all of which have suffered from the same failing as most of VA's IT modernization struggles: poor requirements development. In 2014, VA updated Vista Legacy by developing a graphical user interface, or GUI, and automated some of the scheduling rules. The project, dubbed Vista, scheduling enhancement for VSA, did not address data quality issues and did not bring VA much closer to the then current state of healthcare information systems, effectively putting lipstick on a pig. In 2015, VA has changed directions and contracted for $624 million to implement a commercial off-the-shelf, or COTS, scheduling system, the Medical Appointment Scheduling System, MAS, which has later downgraded to a pilot. By all reports, including VA's own assessment, that pilot was a huge success. VA found increasing scheduling system efficiencies, improved timely access to services for veterans, increased productivity, and a substantial decrease in overtime. However, 8 months after the implementation of MAS and the signing of a contract with Cerner, now Oracle Health, VA halted the pilot. In 2019, VA shifted again, announcing plans to implement the scheduling solution that it had purchased as part of the Cerner contract, known as the Centralized Scheduling Solution, or CSS, but on a separate and accelerated deployment schedule from the rest of the electronic health record. The plan at the time was to have the Cerner application deployed by 2023. This plan, similar to VSE and MAS, was also abandoned. Instead, VA has spent the past 5 years developing its own software, the Integrated Scheduling Solution, or ISS. A system that is currently being scheduled will now take as long or even longer than planned CSS timelines, and is being developed and deployed only to eventually be replaced by CSS anyway. I still don't understand the logic behind this. It seems like a waste of time, energy, taxpayer money to be spent 5 years developing something that would presumably be replaced in the next 10 years, especially when COTS systems have already been tested and integrated at VA with some success. Further, despite these efforts, the ISS is still unable to compare direct care schedules to availability in the community, something it desperately needs as community care referrals continue to rise. The exploiting community care cost is having dire impacts on VA's budget, especially as community care is more expensive than VA direct care. If we don't find a way to balance it, there may not be a VA for future generations of veterans. While community care is a valuable resource for ensuring that veterans have access to the care they need, VA lacks the ability to prove that veterans could be seen faster in community care than they can at VA. In fact, in a broader swath in the country, VA's access is better than that of the community. Central to the oversight of this committee is ensuring that veterans, whether they are seen as VA or in the community, have access to health care that is both timely and high quality. visibility into the community, we are not able to make these quality assurances for veterans as they deserve. I urge VA to implement a solution that allows for apples-to-apples comparisons between VA care and community care. Veterans should be able to make decisions about their health care with the full breadth of information available. Thank you to our witnesses, and I yield back.
Thank you very much, Ranking Member Surplus McCormick. I will now introduce the witnesses on our first and only panel. First, from the Department of Veterans Affairs, we have Ms. Sherry Waters, Executive Director for the Health Portfolio in the Office of Information and Technology. Welcome back, Ms. Waters. From the Veterans Health Administration, we have Ms. Hillary Peabody, the Acting Assistant Undersecretary for Health for Integrated Veteran Care. Finally, we have Dr. Mark Hausman, the Executive Director for the Access Transformation in the Office of Integrated Veteran Care. If you all could please rise and raise your right hands. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you very much, and let the record reflect that all witnesses have answered in the affirmative. Ms. Waters, you are now recognized for 5 minutes to deliver the opening statement on behalf of the VA.
Good morning, Chairman Rosendale, Ranking Member Surplus McCormick, and distinguished members of the subcommittee. Thank you for the opportunity to testify on the Office of Information and Technology and Veteran Health Administration's efforts to modernize the Department of Veterans Affairs scheduling systems. I am accompanied by my colleagues from VHA, Ms. Hillary Peabody, Acting Assistant Undersecretary for Integrated Veteran Care, and Dr. Mark Hausman, Executive Director for Integrated Access, IVC. I am honored to highlight the collaborative efforts that are transforming the future of veteran care. VA's Enterprise Scheduling Modernization effort, a joint endeavor between VHA and OIT, is a testament to our commitment to streamline and enhance VA scheduling systems. To provide the best outcomes for veterans, VA must invest in modern scheduling tools that offer near-term benefits and ultimately facilitate a long-term scheduling solution. The introduction of new functionalities through VA's modernization efforts is a significant step towards improving access to care for veterans. The ability to schedule both virtual and in-person appointments, consolidate scheduling functions, and implement provider-based scheduling is pivotal in aligning VA scheduling systems with industry standards. These enhancements are designed to provide greater flexibility and efficiency in scheduling appointments, ultimately connecting veterans with the best available resources for their needs. One of the key tools driving this effort is the Integrated Scheduling Solution, ISS, which represents a significant improvement from our legacy system, Vista Scheduling Enhancement Graphical User Interface, or VSC GUI. ISS streamlines the scheduling process, offering a more integrated and intuitive platform for VA staff to schedule various appointment types across multiple sites of care. Transitioning users from VSC GUI to ISS is in progress and is expected to be fully completed by February of 2025, representing a significant milestone in our journey towards a more cohesive scheduling system. We have already received significant staff praise during the initial testing and implementation. The Clinic Capacity Search Tool, CCST, and the Clinic Configuration Manager, CCM, are enhancing the scheduling experience for veterans by providing quicker access to care, reducing discrepancies, and increasing efficiency. CCST currently allows VA staff to quickly search and view telehealth appointments across multiple facilities. Starting in January 2025, we will begin rolling out enhancements to CCST that will enable staff to view appointments for both telehealth and in-person visits. Furthermore, we are working on enhancements to CCM for managing the provider's appointment availability. These enhancements will enable the implementation of provider-based scheduling across VA, providing a unified view of provider availability and significantly streamlining the scheduling process. In support of community care, the external provider scheduling platform, simplifies the process of connecting veterans with community care providers. EPS enables VA staff to directly schedule community care appointments electronically, enhancing coordination and ensuring timely access to care. As we look towards the future, our focus remains on improving timeliness, ensuring veterans receive the best available resources, and enhancing coordination between VA and community care providers. These efforts will ultimately converge under the ISS platform, which will integrate multiple scheduling tools into a single streamlined experience across the enterprise. This will provide veterans with faster access to care, whether through VA facilities or community providers, while simultaneously reducing the administrative burden on VA staff. Chairman Rosendale, Ranking Member Sharpless McCormick, and members of the subcommittee, thank you for the opportunity to appear today. We're proud of the progress we have made and remain committed to continuing this journey of improvement for the benefit of our veterans and the dedicated staff who serve them. This concludes my testimony, and I look forward to answering your questions.
Thank you, Ms. Waters. The written statement of Ms. Waters will be entered into the hearing record. We are now going to proceed to questioning, and I will recognize myself for 5 minutes. Ms. Waters, how is the clinical capacity search tool going to make the appointment scheduling process easier and better?
Thank you for that question, Chairman. The clinical capacity search tool will allow a staff scheduler to be able to see available appointments across multiple sites in a single unified view. Currently, this is available to see all telehealth appointments, and as I mentioned in my opening testimony, in January 2025, we're rolling out the next enhancement to CCST, which will allow you to see schedules across multiple sites.
So what are CCST's capabilities today, and when do you expect the system to be fully functional? Fully functional is a term that I have been using since the day I arrived in Washington, and we haven't had it, experienced it anywhere in anything. So that's the big part of this.
I appreciate the question. It's very difficult when we talk about IT tools to talk about what is fully functional. One of the things that we do is we look
Where all of the features that are being promised by the vendor are fully functional. They're working, they're available, they are ready.
So as I mentioned, the current state of CCST allows you to see available telehealth appointments across the enterprise. And in January 2025, we are rolling out the next enhancement, which will allow us to see available in-person appointments in that same unified view.
So will all the features then be functioning?
Again, with IT systems, it is always our hope that we are continuously making incremental improvements, and we'll be working with our partners in VHA.
So I'll take that as a no. All of the features will not be fully functional in January of 2025?
All of the features that we have defined today will be available in January of 2025. That is
Okay.
correct. We are always looking for opportunities to enhance and improve things.
You just began rolling out the integrated scheduling solution this month. Will it improve the scheduling process, and what are its initial capabilities?
Yeah, so ISS is going to vastly improve the ability to schedule appointments. So ISS is initially designed as a replacement for VSE GUI, but we are already seeing incredible improvements with this tool. Examples of this include the fact that it's designed to be in a web browser, so it's got a much more modern user interface. It is not dependent on a desktop application, so it runs faster for the scheduler to be able to utilize, and it allows them to then move from one VISTA system into another VISTA system to schedule appointments without re-authenticating. So it makes that experience much better for the user. The redesign of the system also makes it much easier for us to do enhancements to the system because it's no longer dependent on a desktop application that will sit on 600,000 desktops. we're not beholden to that as we want to do incremental enhancements and do improvements to the project.
What will its full capabilities look like, and when will those be implemented throughout VHA?
So again, with IT systems, we are hoping to always build requirements and do enhancements to it. Right now on our roadmap for ISS, not only do we have the ability to schedule across multiple facilities, we'll be working to integrate the view from the CCST tool and to work on the ability to schedule external provider appointments or through EPS through the ISS platform.
And when do you expect all of this to be implemented throughout VHA?
I do not have that date at this point. We are still working on the requirements that we need to refine that date, but I am happy to come back and brief you on that.
Thank you. Thank you very much. Ms. Waters, why are these two systems, CCST and ISS, being developed separately, and what will it entail to eventually combine them?
So they're being developed separately at this point. It allowed us to do a much more rapid glide path to build those tools out. They use the same back-end infrastructure and architecture and refer back to the back-end EAS system. It was simply for ease of convenience and the ability to rapidly deploy them that we did them separately with the full intention to combine them in the future.
Okay, thank you very much. I will yield back, and I now recognize Ranking Member Surplus McCormick for 5 minutes questioning.
Thank you, Mr. Chairman. Ms. Peabody, at this subcommittee's last hearing on VA's patient scheduling IT system, the witnesses discussed VA's plan to separate CSS from the rest of the Cerner suite of applications and deploying in ahead of the rest of the EHR. Excuse me. That plan was abandoned during the pandemic, and I'm still unclear as to why. What is the VA's logic for choosing to develop another homegrown solution versus deploying the tool that the department had already purchased?
Thank you for that question, Ranking Member. I'm actually going to hand that one to Dr. Hausman.
Yeah, thank you, Ranking Member. So, yes, there in Columbus, the central scheduling solution or Cerner-based scheduling solution was implemented in August of 2020. And following that implementation, an evaluation was performed. And ultimately, the decision based on the evaluation was that while this can work layered on a VISTA electronic health record, the cost and the disruption to clinical operations outweighed the value gained by moving forward with this strategy. And specifically, in order to implement this scheduling solution, every single clinic, so thousands of clinics, had to be rebuilt and reconfigured in a way that's compatible with Cerner, which puts capacity limitations and access limitations on the medical center for weeks to months to get this done. And one other point is there is an incremental cost with licensing with this, so there would be additional expense to license this scheduling product across the enterprise. So in summary, the thought was instead of having two disruptive events, implementing scheduling, Cerner scheduling, and then later implementing the Cerner EHR, it made more sense to implement both at the same time.
Are you not doing the clinic rebuild for ISS?
We are not. So ISS is currently, as of this month, being deployed in its initial phases, and that deployment is going to run over the next 5 months. We are able to seamlessly integrate this version of ISS with all existing VISTA clinics.
And what would the cost difference be between what would the cost difference have been before, been for VA to deploy CSS versus the development of ISS?
I don't have those figures. That's something we can take back and get you an answer.
What was the decision-making process for this strategy, and who ultimately made that decision?
I think that's another question we'll need to take back to get you the right answer.
Ms. Waters, VA has a long history of IT modernization efforts suffering from the lack of effective project management, and requirements development does not meet the VA's needs. How does the planning for a Cerner scheduling solution deployment differ from what has been going on in the past?
So I'm not sure, and let me please clarify, are you speaking to the Cerner scheduling deployment or the integrated ISS scheduling deployment?
ISS.
Thank you for that clarification. And thank you for the question. One of the things that we are trying to do with ISS is adopt an incremental approach, and that's, again, goes back to that answer of fully deployed versus deploying a tool and then making enhancements to it. We firmly believe that when we do an incremental approach, the way that we're doing, you'll see a quicker rollout and adoption across the enterprise that then allows us to move the organization with each enhancement that we deploy.
And how does the VA plan to avoid or mitigate the risk of outcomes similar to the past failed IT projects?
So what I can say is that we are working very diligently in a collaborative effort in IT with VHA to work together. With any one of these implementations, it really requires movement in both people, process, and technology. If you only move one of those things, you're likely to suffer failures.
So there's no plan? My time is running out, so
Yes.
there is no plan?
I guess I'm not sure that I understand your question.
So you
I'm
don't
very
have a
sorry.
plan to avoid or mitigate the past failures?
Our plan to mitigate the past failures is to ensure that we are working in a collaborative format, doing incremental improvements so that we can ensure success at every step along the way. And I think we are demonstrating that with our current rollouts.
And so you've made an assessment of all the failures and now have committed to avoiding that?
I cannot speak for what happened before me. So I cannot say that we have done an assessment of all the failures. Certainly, we do have an understanding of why we've stepped away from other solutions.
Thank you. I yield back.
Thank you very much. Ms. Waters, we just touched on, and Dr. Hausman just touched on the MAS medical appointment scheduling system ranking member was asking about. I do want to make sure that we get the information on the record about what the thought process was and who was responsible for the decision to end that system. That's very important. So we will be looking for that information to come back to us. Dr. Hausman, could you briefly describe the steps the VA schedulers go through to schedule veterans community care appointments without WellHive?
Yes, Mr. Chairman. So it starts with a referral or a request for care. And from there, we have referral coordination teams that evaluate that request to determine if a veteran is community care eligible based on access standards. Once eligibility is determined, a veteran is offered community care, the best community care option we can find, as well as the best VA option that we have. If a veteran opts into community care, then we begin the process of collecting preferences. So where, geographically would you like to see your provider? What days and times tend to work best for you, those types of things. And from that point, we begin the process of telephoning. So we need to reach community provider offices to determine if they have available appointments, when those appointments are available, and we, of course, target that search based on the preferences the veteran gives us. That really can be one of the areas for delay in getting veterans appointed to the community, is the need to have synchronous communication through a telephone, and that can take some time.
So if anybody was trying to create a flow chart just now on that process, it didn't really look good, okay, from my standpoint, because there's a long path before the veteran actually gets that care, okay, where we need to get a more direct path, if you will. How long does this process take with and without WellHive?
So this last quarter three of this current fiscal year, we are scheduling veterans from the moment in time care is requested to when they're first appointed in the community in just over 21 days. If you look at a head-to-head comparison of scheduling veterans to light care using our traditional process versus WellHive, it's about a 26-day with the traditional process versus 17 days with WellHive. That's the difference. So substantial time savings and improvement in timeliness with using the EPS solution.
Okay. On average, how many community care appointments are VA staff able to schedule per day using WellHive versus the current system?
Using the WellHive software, a trained, seasoned scheduler can schedule upwards of 20, maybe 25 appointments per day,
And without?
about 8 appointments.
About 8, okay. What are the VA schedulers saying about WellHive, either in surveys or anecdotally? What kind of feedback are you getting?
The feedback for those that have used the system, which is now, the number is in the hundreds, has been uniformly positive. I think the greatest challenge is having appointments available in this system. In other words, if
Slots open, availability?
in the right specialties for the right type of care. That's correct.
Okay. Please explain what file entry date to first appointment means.
File entry date is the moment in time when care is requested by a veteran, or in the event of a primary care provider and a veteran generating a referral for specialty care, it's that moment in time that referral is generated. So that's file entry date. And first appointment is the moment in time when the appointment for that care is scheduled.
Okay, so one of the things that I've seen in the past is that the first appointment date sometimes gets skewed because it gets canceled, and then the initial appointment for the veteran gets transferred out, sometimes several times, so that their true first appointment may not be for many months after that. So I would really like to see if there's some way that we can get more of an accurate reflection of those times as well. To not just the first appointment date when it's set, but when it's actually experienced, if you will. Okay, when it takes place, so that we can see the true time frame between when they contact and when they're getting that initial care for health care. Okay? I'm close enough. I will go ahead and yield time to ranking member.
Thank you. Ms. Waters, I can't help but recall your response of not knowing what happened before you were there, because it just makes me feel like if we don't understand the mistakes we did in the past, then we're capable of repeating it. And the committee really wants to make sure that implementation going forward is not repeating the mistakes of the past. And so, hopefully we can get back and you guys can actually take a real good assessment of that, and we can make sure that we're not repeating that. My next question is also for Ms. Peabody. What is the OIT's role in the ISS project?
Thank you for that question. So I'll start, and then I'll ask Dr. Hausman to add on, because really it's his team and Ms. Waters' teams that have been working in the trenches together on this. So OIT has been a really valuable partner for us in VHA, and Dr. Hausman's worked very closely in partnership with our colleagues in OIT to actually stand up a very unique governance structure where we have a working group that includes our OIT counterparts and key VHA stakeholders, and they're working hand in hand to develop that scheduling roadmap. So OIT's role, coming back to your question, is really to take the business requirements that VHA puts forward and help us design the solution and then be able to fund that. Anything to add, Dr. Hausman?
Thanks, Ms. Peabody. That's correct. A strong partnership between VHA and OIT on this project is critical. I believe we have a strong partnership in place. We set the requirements, we set the priorities, we do the testing of the initial versions of the product, the user acceptance testing. We also do the training, deployment, change management. OIT takes our requirements and our prioritizations and develops these products or enhances the products. And also those prioritizations and requirements inform the roadmap for the timing for some of these bigger milestones that we're working towards.
Is OIT's role prominent enough to support solid project management and to help prevent, Ms. Waters, is OIT's role prominent enough to support solid project management and to help prevent previous mistakes?
Thank you for that question. And please also let me clarify that my answer when I reflected that I personally wasn't aware of some of those challenges and decisions that were made in the past. Rest assured that there are strong teams behind me in OIT that are very aware of them and are taking them into account. So I probably misspoke when I said I wasn't aware of them. Let me also share that on this initiative, it is critical that we have strong PMs available and working with the team. And we have teams that are working day in and day out with Dr. Hausman and his team that are dedicated to making this effort a success.
And how is the requirements development for this project different from VA's previous struggles to modernize patient scheduling applications?
So again, with this adoption that we are doing it in a collaborative, shoulder-to-shoulder format, day in and day out, working with our partners to ensure that we're doing it together.
Wonderful. And Ms. Waters, you're leading your teams, correct?
That is correct.
And so as a leader of your teams, do you feel like you should be aware and do that analysis for your own knowledge to lead your team?
Yes, of course. But I also trust my teams and the leaders that I have on my teams.
Thank you. Ms. Peabody, I understand that VA is rethinking its strategy for the external provider scheduling project, that you're looking at paring back the number of sites using the EPS tool. What is the VA's goal in this reformatting effort?
Thank you for that question. So our goal is really to take the lessons that we've learned from the first 2 phases of the rollout this year and refocus our strategy to secure more success. So one of the biggest challenges that we've had in rolling this out is getting enough providers enrolled on the platform so that the scheduler, when they log into the EPS system, they can actually find a provider and they're not having to then revert back to the standard processes of looking for a provider elsewhere.
And how many facilities are using EPS?
I'll tag that to Dr. Hausman.
16 facilities are currently live on EPS.
All right, thank you. I'll yield back.
Thank you. Dr. Hausman, I want to go back to the file entry date first appointment issue again. With all of this advances in technology and improvements that we're making, is it true that the goal was recently changed from 7 to 14 days to actually extend it out?
For community care appointments, sir, I know there was discussion on changing that goal. I'm not sure if that decision has yet been made.
So if we're having improvements, Ms. Waters, and things are flowing better, and we're making all these investments in the technology, that just seems counterintuitive to me that if it's working well, if we're making improvements, that we would be setting the goal out longer, doubling it, literally doubling it from 7 to 14 days. Have you seen that information? Are you telling me that you have not seen and participated in discussions in that regard?
I'll defer to Ms. Peabody to answer that, sir.
Thank you for that question. So I want to clarify that these metrics, when we're talking about FED to first scheduled, that's what we call internal schedule timeliness. It's very different from wait times. Now, both of those measures are important for us to track and monitor within VHA, and we set goals around that schedule timeliness because that's really our measure for our schedulers within VHA to be able to do the piece of this that is their responsibility. We have been exploring changing what are those goals. We had some very strong feedback in a report from the GAO several years ago, and we have had an open recommendation to relook at that schedule timeliness metric and to reconsider it to something that's more realistic for our facilities. So we have undertaken through our access committee a look at different options for that we have recently just brought up through the VHA governance structure.
Okay, so Ms. Peabody, you have seen this recommendation then or consideration from the 7 to 14 days?
Yes.
Okay, again, counterintuitive to everybody that's sitting in this room. If we're making improvements, if we're making investments, and everybody is telling us that we are making these strides towards a smoother system, why would we not be taking the goal and pushing it the other direction? This just doesn't make sense to me that we're talking about extending it, doubling it from 7 to 14 days.
Thank you for that question. So I would add there's some nuances, and we can take it back for the record to get you the specifics of what we are looking at changing in that metric.
So why has it changed? And whether it's Dr. Hausman or Ms. Peabody, why would they change this number again if we're making improvements?
So we have looked at different options for changing that measure and several different ways to measure that. What's most important is that any urgent consults, our measure continues to be that those need to be scheduled within 2 days, and I looked at that measure this morning, and we're sitting at 100% of those. So for those non-urgent consults, we do want to allow our schedulers enough time to be able to make contact with the community provider and with the veteran to schedule that, and we've...
Okay, Miss, I'm working on my time here, so I just don't understand, okay, as a person who has always had his compensation based on performance, how in the world you can ever expect better performance if you set the goal lower? That just, again, it's counterintuitive. If you take the goal and you make it lower, that matrix, you're never going to improve the situation. If you set goals that are less than what you have now, standards that are lower than you have now, how are you ever going to make an improvement? It just doesn't work. You have a section touting external provider scheduling, AKA WellHive, on your community care network on your page. Information website for providers. Does the department endorse this system and encourage community care providers to sign up and use it?
We do encourage community care providers to sign up for our external provider scheduling platform.
Okay. What is the process to solicit and recruit providers into external provider scheduling? Ms. Peabody.
If I could, I'd like to hand that to Dr. Hausman.
Thank you, Mr. Chairman. The process begins with selecting from our community care provider network of 1.3 million, the highest potential providers with whom to engage, and engaging with them to explain the program, explain the value of the program, the importance of this program, the vision. Then from there, make sure we get with the right decision makers and discuss the process. How does a community provider system participate in this? We get into the technical requirements, and then from there, if we have an agreement, we do the process of onboarding, which actually is the technical integration of their schedules into our WellHive user interface.
So my time has expired. Ranking member, I yield 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Peabody, what do you believe is limiting provider enrollment in EPS?
Thank you for that question. As Dr. Hausman was just articulating, the longer piece of the onboarding is actually that technical integration, and there's a fair bit of work on the provider. So the provider has to have the ability to actually know their appointment availability and to be able to pass that into our system and be able to do that technical integration with our team. That can be very lengthy and a significant investment of time for them. At this time, we have not put in place any types of incentives or run this through our community care network contract. We have done a significant amount of market research, actually through our CCN Next Generation contract recompete efforts to gather some market research on how do we actually incentivize providers to do that. And we've received a good amount of feedback on what that would look like. So as we look further on down the road, how we'll make this successful, we know that we're gonna have to have some sort of carrot, if you will, for providers.
Also, when we took a look at it, South Carolina was successful, whereas Orlando really struggled. One of the differentiating factors we saw was that the staff and the providers were more involved. And so really supporting the system made a huge difference, but we didn't see that in Orlando. So is the VHA properly supporting their enrollment efforts?
Yes, we have made this a priority, and in fact, this has been an initiative that myself and Dr. Hausman have briefed several times to our governance board, which is VHA's highest governing body. So we've got full support behind this, but it's just important that we really step back and take some of those lessons we've learned over the last several months and pivot a little bit in that approach, because we need to do that to make it successful.
So the lessons that you learned from doing the analysis of these two sites, that hasn't been done yet, the analysis?
Yes, that has been done, and our refocus strategy is a direct result of that analysis.
Can you tell us some of the pieces that you're plugging in to make sure that they're actually, that the other clinics don't have this kind of struggle?
So I'll start, and then I'll ask Dr. Hausman to help fill in any gaps here since he's been leading this effort. So the biggest thing that we've learned is that when we try to do this big bang approach across the entire system, it's a pretty significant level of effort for us to do that provider outreach and start integrating each of those providers. So when we initially took this approach of let's just do it everywhere at the same time, we found that we got, several providers here and there, and it was sort of a smattering. When the scheduler logs into the system, if there's only, a handful or a few handfuls of providers, they're having to go back and forth between systems, and it is impacting the trust that they have in the data that's in that system. So we feel taking that focused approach so that we can really, really do it well at a few sites and then be able to expand from there, that's going to be more successful.
Thank you. Also, is VA planning on pulling the tools from any facilities?
Yes.
And what is the long-term plan for EPS?
Dr. Hausman, do you want to address that?
Yes, I'm happy to. Thank you. So we do see EPS as the enterprise solution for community care scheduling. At the end of the 2025 fiscal year, we intend to have EPS live in approximately 1/3 of our VA medical centers. That's about 50 sites across the enterprise in focused regions. And then we anticipate being successful. What I mean by that is attracting and enlisting the participation of a large number of larger, higher volume community care providers into this program over the next year, and then booking more appointments through EPS. And specifically, we're looking at least a 10-fold increase in provider participation, as well as appointments booked compared to what we're looking at this year. That's how we define success for next year. Now, beyond that, we intend to continue to roll this out across the enterprise to the other medical centers and other VISNs that are not part of the 25 plan.
Thank you. I yield back.
Thank you very much. Ms. Peabody, what is the process to solicit and recruit providers into the external providing scheduling?
Thank you for that question, Chairman. So we have both a team within Dr. Hausman's team as well as a vendor that we've been using to support some of those onboarding efforts. So we take several steps in this process. One, our team has been traveling to conferences, doing webinars, posting in our newsletters just to get the word out. And then the provider that's interested can reach out to us, and our team will start that process of onboarding and walk them through that.
So when you were talking earlier about focusing your attention instead of trying to do just a what I'll call a shotgun approach and cover the whole country, focusing in, and we're going to use a rifle and a scope, and we're going to zero in on some areas and concentrate the effort to try and get those providers. That's starting to make a little bit of sense to me. So is that why there's such a discrepancy in the number of participating providers in WellHive in, say, South Carolina, which has numerous, and Montana, which has a couple of dozen?
Thank you for that question. Yes, I would agree with that assessment. And I think in some areas, if we're able to get the affiliate or one or two of the large hospital systems, so this works really well in more urban areas where you have one hospital system, you could bring that whole system in. It's been really successful in areas like Montana. It's a little more sparse. So
it's
harder to
rural.
do
That is exactly right. So what is the thought process, or how are you identifying where to focus those resources, okay, to go in and recruit and get these providers listed, and what's that list look like, and what's the criteria that you're using?
Yeah, so I'll start, and Dr. Hausman will definitely help make sure I don't miss anything here. So we started actually by sitting down with our CCN contractors and getting some feedback from them, because it's their network of providers predominantly. And so they know which providers are most likely to be open to doing this, and the team actually focused which VISNs and medical centers where we would go next around some of that feedback. We also gathered that just from our own experience. So we have to consider just where is their appetite to do this. And this is very leading edge kind of stuff. In the private sector, you don't see a whole lot of this. We're starting to get there with more providers being willing to open up their clinic grids and do the work to integrate into some of these platforms.
So far, I have to stop you. The one concern that I have is that what is the input from the actual patient? What is the input from the veterans themselves? Because if we start basing too much of our information on these large providers, forgive me for using the term, but there is a medical industrial complex out there. They will try to completely dominate the services. And as a former commissioner of securities and insurance, I can tell you that every single study that has ever been put out shows that the bigger the organization is, the bigger the administration is, the bigger the corporation, the medical corporation is, that the lower the quality of care is and the higher the cost is. And so I need to hear something that says we're talking to those veterans, especially in the rural communities like Montana, that maybe are not going to have access to a large facility, that we have a team that understands this and is going to go out and recruit and sign up physicians that the veterans want to access.
Thank you for that question, Chairman. Yes, absolutely. In fact, our team did, I'm sure you're very familiar with V-signals. That's how we get the most, a big portion of our feedback from veterans. We actually rolled out a V-signal specifically for EPS, and we got some really, really impressive results. So we are continuing to get that feedback from veterans as well.
So again, what would it look like to have a team? If we're going to go out and I understand we have the electronics and everything, but to actually have a team to go out and start trying to go around to these areas that not necessarily are urban, the very rural areas, and start getting some providers to sign up.
Thank you for that question. We do have that in place today, and that is that separate vendor contract that's supporting us with going out and doing that onboarding. And then we're also looking at options perhaps in the future to be able to leverage our CCN contractors to help us with that.
Okay, thank you. I yield back and recognize Ranking Member.
Thank you. Ms. Peabody, as I said in my opening, I'm convinced that VA must address the lack of a fully integrated scheduling solution. We are extremely concerned by the exploding community care costs. I'm particularly concerned that much of the cost may be unnecessary, but VA cannot prove that as they cannot compare access in apples-to-apples manner. What is the VA's plan to address this shortcoming?
Thank you for that question. VA is committed to making sure that the care that our veterans are getting in the community is clinically appropriate and that they're getting that care at the right time and place. And so since I stepped into this role as the Acting Assistant Undersecretary for Health for Integrated Veteran Care in February, I actually spent some time resetting what our mission statement is and what our 3 priorities are as an office. And one of those 3 priorities is ensuring that when our veterans do go out to the community, that the care that they're getting is high-value care. And we'd be happy to do a briefing on several of the initiatives that we're doing, but that includes making sure that we have a high-performing provider network, and we're able to see where the providers that are in our network are actually highest performing and have the best quality measures and be able to give that information to our veterans. And that also includes doing a more robust utilization management program in the future.
Thank you. The vendor who supports the EPS project has this capability. It was part of the pilot program. Why did the VA choose to shut it down?
VHA, thank you for that question. VHA has not chosen to shut down. In fact, based on the pilot, we gathered market research from industry to identify options for how we could procure a similar solution in the future, and then moved forward with an acquisition plan to do that, which resulted in actually having the same vendor from that pilot.
It seems to me that the VA is making short-sighted decisions that are focusing veterans to continue waiting. Is there anything that you would recommend as committee do to help and support make sure that there aren't any failings and that this is actually sufficient moving forward?
Thank you for that question. We appreciate your continued support for efforts like this one and for continuing to hold us accountable for ensuring that our veterans get the care that they've earned and deserve.
Thank you. I yield back.
Thank you very much. Ms. Peabody, I understand your office has decided to make cuts to the external provider scheduling. We're going to get into the reasoning in a moment, but I want to understand what the cuts actually entail first. Is it correct that the VA medical centers in West Haven, Connecticut, Hudson Valley, New York, and Ann Arbor and Iron Mountain, Michigan currently have WellHive activated and that it will be turned off?
Thank you for that question. I definitely want to ask Dr. Hausman to make sure I get this right.
That is correct.
Okay, so Dr. Hausman, I really don't understand this because when we were just talking about the file entry date to first appointment and the time that it's reducing, that it's making these improvements, why would this be being turned off?
So we are active at 16 medical centers. We will continue to be active in 12 of those 16 medical centers moving into the next fiscal year, plus adding 5 additional entire VISNs into the mix. So this was a decision made by our VHA governance board, and really I think the decision was around solving the issue of having acquired licenses this year that we simply cannot use because we don't have adequate number of community care providers yet participating in this program. So the strategy that we're putting forward and we're going to be working towards next year will allow us to focus on key areas, so markets and VISNs that we think are highest potential for a lot of the considerations that Ms. Peabody already mentioned. And with this revised strategy, there are 4 medical centers, 2 in Michigan and the other 2 that you mentioned, that will be paused for this next year.
So, Dr. Hausman, Iron Mountain, Michigan has a very few community care providers signed up, but Hudson Valley, New York already has hundreds. Why did you decide to turn off both of these facilities, and what message does that send to providers that WellHive already has in New York and the providers you're hoping to recruit in Michigan?
Yeah. Well, we hope the message will be that we believe in this program and we are going to be back to building and activating this program in these areas very soon. In the instance of Hudson Valley, while we do have around 300, almost 300 providers that are on board, this was the first area that we built out, and we didn't focus in the way that we should in terms of engaging providers to do higher volume of care, more veteran care, higher quality care. So we built this out in a way that we learn from. So strategically, we're going to be focusing on working with providers that do higher volume of care, that are known to do high quality care, and that also have a good relationship, that we have a good relationship with, for example, academic affiliates.
Again, to me, as a consumer, I hear somebody shutting down after they have opened up a system, a facility, whatever, and they're telling me how great it is, but yet they come in and say, but you're not going to have it available to you. We're going to go out and try and sell. I don't see how that's going to help efforts going forward to get other providers to sign up. I just don't. I think it is a very, very poor marketing concept. Are you concerned that when you decide to turn WellHive on again in Connecticut, New York, and Michigan, the providers will be frustrated and suspicious about working with VA?
We appreciate that those sentiments may exist as we go to reactivate. I do believe that the messaging that we put forward, the communications that we're going to be putting forward to these community partners now is going to be very important in how we message this decision and why we're doing this, and also the idea that we will be coming back likely in the beginning of 26. So there's definitely some communication that will be taking place that will hopefully keep the relationship with these providers strong and keep them interested in participating in the future.
And even, again, the future providers that you're trying to sign up, when they look and see that you are basically pulling the rug on the other providers, I can't believe that it's going to give them a level of faith in participating. I mean, can you understand that?
I do understand that concern.
How much is the cut to the external provider scheduling project? You told the committee staff that $20 million during a meeting, is that correct?
That is approximately our budget for this program in '25.
So this system that seems to be working, that is helping us schedule better, that is providing better health care, is the place that we're going to have a $20 million cut.
Approximately.
Ms. Peabody, was this cut your decision? And if you didn't make that decision, who did?
Thank you for that question. Our VHA governance board made the decision unanimous to take on.
Did you make it as a recommendation to them, or did they come up with this amongst their collaboration and their work?
That was IVC's recommendation, yes.
That was your recommendation?
Yes, sir, that was my recommendation based on the inputs from Dr. Hausman and his team.
Okay, I will now yield 5 minutes to, oh, I think that puts a pin on it then. I'm good. Okay, I would recognize the ranking member for any closing remarks that you may have. Don't have any? Okay, no closing remarks. Okay, I want to thank our witnesses for joining us today. VA scheduling process and technology directly affect veterans' health care, obviously. Outdated, dysfunctional systems increase veterans' wait times and may discourage them from getting care from the VA altogether. We have to remember that most veterans also have Medicare or private insurance. As the billboards say, the Department of Veterans Affairs wants veterans to choose VA. That means getting an appointment has to be user-friendly. This morning, we've heard about some real accomplishments in internal scheduling and direct scheduling that are improving veterans' experiences. We also know that the VA has a troubling history of snatching defeat from the jaws of victory when it comes to technology projects. I urge the committee to continue rigorous oversight in the next Congress to prevent that from happening again. I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered, this hearing is adjourned.